some guidelines about that's the area of focus of this speech. Next slide, please. UTI, is the most common bacterial infections humans undergo. It generally involves 1 to 3% of the worldwide female population is affected by this infection. And the lifetime risk of UTI in a given woman is 50%. That is, you have always, as a woman, 50% chance to get UTI. And 10% of these infections can be recurrent. That's another problem with this infection. And in this UTI, 40% of this is hospital-acquired infections, and most of them are due to the urinary catheters. And if you take the hospital-acquired gram-negative sepsis, almost 50% is due to the urinary infections, and it leads to morbidity and more cost. That's why we are focusing on this topic today. Next slide. Next slide. This is the antimicrobial monitoring data from this Southern India. Next slide. If you look at the organisms causing urinary tract infection, E. coli dominates even in our part, almost 60%, followed by Klebsiella, Pseudomonas, and other gram-negative pathogens. Next slide. If you split up this data into complicated and uncomplicated, just to note that if you think about uncomplicated UTI, E. coli is the most common cause. And if you think about slowly about complicated UTI in a predisposed individuals, even Pseudomonas, other gram-negative pathogens contribute significantly. This actually has an impact on choosing your therapy in patients with complicated urinary tract infections. Next slide, please. So you have to be clear when you diagnose somebody as UTI at which point and with this spectrum they belong to. These are the basic categories of UTI. So whenever you diagnose UTI, UTI has cystitis or UTI in pregnancy or acute pyelonephritis or asymptomatic bacteriuria or complicated UTI. Let's briefly go through each of these and get some treatment protocol also. Next slide. So cystitis is infection of the urinary tract which are limited to the bladder. It involves only the mucosal surface, and it is the most common form of UTI. Next slide. Pyelonephritis is a scientific infection involving the renal parenchyma. Next slide. Urosepsis is when you document somebody with urinary tract infection having developed sepsis, that is documented infection by positive culture and a systemic inflammatory response, which is defined by this criteria of the ACCP. Next slide. Asymptomatic bacteriuria. So asymptomatic bacteriuria has different definitions depending on the subgroup of individuals. In case of women, it is 2 consecutive clean catch specimens of 10 to the power of 5. In men, it is 1 single in culture of 10 to the power of 5 is enough. If it is a catheterized sample, these 2 belong to non-catheterized. If it is a catheterized sample, just 10 to the power of 2 is enough. Next slide. Pyuria is just presence of WBC. It may or may not denote urinary infection. But if presence of urinary culture positivity, if you have pyuria, this means most likely the patient has UTI rather than asymptomatic bacteria. That is the clinical relevance of pyuria. Next slide. Catheter-associated UTI. This is the most, in fact, will likely to become the most common subtype of UTI in future years. The risk is 1 to 2% per procedure. If you look at keep the catheter for more and more time, more chance of getting UTI is there. It is just 100% by the time when you keep the catheter on 1 month, especially in paraplegic individuals. And not all this bacteriuria is going to become symptomatic UTI. In a way, 1 in 5 of this bacteriuria is going to convert to symptomatic UTI. And the risk factors are history of previous catheter use and length of stay and location where the catheter is inserted. Next slide. Complicated versus uncomplicated. This I would say is the most important slide of this entire presentation. Complicated UTI means you have a condition which predisposes you to UTI. It can be a functional damage or it can be anatomical defect like lower urinary tract anomaly like posterior urethral valve or urethral stricture, or it can be just presence of a predisposing condition like diabetes. So any of this, either a functional or anatomic or a predisposing condition, characterizes their complicated urinary tract infection. And any UTI in men always considered complicated. You have to treat it as complicated urinary infection. Next slide. Recurrent UTI, there is 2 subsets. One is the reinfection, other one is the relapse. This is just to know how are you going to treat these subsets. Reinfection means the different microorganisms after 3 weeks, usually it's a drug susceptible, usually it's a lower urinary tract problem. Whereas the relapse is infection due to the same organism. Often it is within 2 weeks. It is opposed to reinfection, which is more than 3 weeks. And it is often pyelonephritis or prostatitis. That's the real difference between these two substances. Next slide. Pathogenesis I am not going to concentrate, but in general it is ascending infection. Rarely, next slide. Rarely it can be due to the hematogenous spread, particularly with gram-negative sepsis, candidemic individuals, and in Mycobacterium tuberculosis. Next slide. When to work up, there is a rough guideline which is available given below. In presence of indwelling catheter, either one of these two is enough. Like if somebody has fever and chills in presence of indwelling catheter, you need to work up for urinary tract infection. Whereas if there is no catheter, fever, chills frequency, urgency, conservative language tenderness, altered mental status, new onset, hematuria, foul smelling urine, or suprapubic pain. So either one of these is enough to label somebody as UTI and initiate further workup. Next slide. Clinical features is well known. Just to say that upper UTI has fever and chills and flank pain, which is classical of upper UTI more than this lower UTI. They can only present as just lower urinary tract symptoms of any kind. Next slide. The gold standard to diagnose urinary tract infection is urine culture. In general, midstream urine is the urine which we collect because the initial urine represents the urethral urine, the midstream urine represents the bladder urine. The first voided morning specimen is the most ideal. The reason they say is urine has to be there in the bladder for 4 hours at least to have some bacteria proliferation there. If you just take urine when a patient just voided, it can give rise to false negative finding. But any bacteria in a suprapubic urine is more significant. I mean, it is diagnostic of urinary tract infection. Next slide. Prevention by taking more fluids and clot voiding. This is voiding every 2 to 3 hours just to avoid retaining urine in bladder, and voiding after coitus. That's very important, particularly in women. Next slide. Next slide. Proper hygiene. You have, particularly women, this is very important. They have to wipe from front to back rather than back to front because that will push the rectal bacteria into the urinary tract. Taking showers instead of tube tub baths because again bacterial entry is a possibility. Taking cranberry juice again decreases bacterial colonization. And using alternate methods of contraception, particularly when you use spermicide or diaphragm, etc. Next slide. And complete the entire course of medication. That's important. That's why I put that category first. Next slide. And in patients, in hospitalized patients, at least up to 40% of patients, Foley's catheter is not justified. Applying condom catheter alone may be enough. In patients who are dependent on Foley's catheter, you can think about suprapubic catheter rather than keeping a Foley's catheter because it is associated with lower incidence of bacteriuria. Next slide. Treatment. So in treatment of urinary tract infection, first categorize the urinary tract infection, what it is, then decide on duration, drug choice, and antibiotic concentration in the urine, and prostatic penetration in males. Next slide. In case of acute uncomplicated cystitis in women, it has been clearly found that the short course therapy is superior to the single double strength dose of cotrimazole or any other antibiotic. So the recommended duration is 3 days. Drugs of these, trimethoprim or combination with sulfamethoxazole or fluoroquinolone. Next slide. In case of pyelonephritis, uncomplicated pyelonephritis, there is no ideal regimen to say this is the drug to be used. But in general, combination of beta-lactam and beta-lactam inhibitors are the ideal choice. Aware of the local antimyograms before you prescribe your drug. And this is the most important disease that is emerging. We keep on using fluoroquinolone as a first choice, but if your data says your fluoroquinolone resistance is more than 20% of in your population, don't use fluoroquinolone as a initial choice. And continue till the patient is afebrile, at least for 3 days, then start oral antibiotic therapy for 14 days. So the duration of treatment for uncomplicated pyelonephritis is 14 days. And if there is no response, look at complicating factors. And most importantly, in pyelonephritis, many patients will have underlying renal insufficiency. So you need to adjust your dose according to the level of renal function. Next slide. In elderly women, you need, in addition to this, you need to add vaginal estrogen cream or oral estrogen supplementation. Next slide. In complicated UTI, we all know there is high burden of ESBL producing E. coli and other gram-negative pathogens in India. And there is more and more trend towards increased So the empiric treatment in complicated UTI include either carbapenem or piperacillin tazobactam, and the second choice being aminoglycoside, tigecycline and polymyxin as choices. And again, treatment of complicated UTI duration is 2 weeks. Next slide. UTI in men, the most important thing is even if you get a cystitis in men, you need to treat them at least for 2 weeks, because short course therapy is associated with high relapse, because all the bacteria is going to be there in the prostate, which is not going to get removed. In case of chronic prostatitis, the duration is 6 weeks of antibiotics, and you need to choose drugs which have a good prostatic penetration, and you need to assess them for lower urinary tract problem in case of treatment failure. In chronic bacterial prostatitis, in patients who have recurrent UTI with bacteria in the prostate, you need to treat at least for 3 months. Next slide. During pregnancy, UTI can be due to asymptomatic bacteriuria, cystitis or pyelonephritis. Next slide. Asymptomatic bacteria in pregnancy needs to be treated because it is associated with increasing risk of pyelonephritis at least in 20%. And these patients likely to experience premature delivery and problems in childbirth. And the antibacterial treatment has been well established to reduce the risk of subsequent pyelonephritis by 10 to 40%. Next slide. How to screen for asymptomatic bacteria? In all women, you have to screen at the first visit. In case of sickle cell triads, because they have very high chance of asymptomatic bacteria, you need to screen during each trimester. And if suppose initial screening is positive, even after treatment, you have to keep them screened. And if the initial is negative, no further screening is recommended. Next slide. Treatment during pregnancy. In asymptomatic bacteria and cystitis needs to be treated in the same way, like in reproductive age group. The duration of treatment is 3 days. Drug of choice is beta-lactam. Prefer to avoid chlorotrimazole and fluoroquinolones because of the teratogenic risk. Next slide. Indications to treat asymptomatic bacteria is the pregnancy, prior to urological procedures, and in post-transplant individuals. The choice of asymptomatic bacteria treatment is based on culture, and the duration is 14 days, except in pregnancy where 3 days treatment is enough. Next slide. No treatment for asymptomatic bacteriuria is recommended for diabetic patients, elderly, patients on indwelling catheters, spinal cord injury. This is the common practical mistake we make. We keep doing urine culture and treating them for asymptomatic bacteria, and this is associated with emergence of resistant pathogens. Next slide. Reinfection and relapse I briefly told. In case of reinfection, it is generally due to anatomic and functional problems, so these patients may likely to treated by long-term antibiotic prophylaxis. Whereas in case of relapse, you need to treat them for long duration to eradicate the foci. Next slide. Catheter-associated UTI, the risk factors which I have mentioned earlier. Next slide. Treatment should always be based on culture sensitivity. Catheter should be removed. If suppose you have a catheter and positive urine culture and patient has fever, you need to remove. And if you cannot avoid further catheterization, put a new catheter. The treatment of choice is usually, as I mentioned earlier, carbapenem or piperacillin tazobactam. And in case if the catheter, though there is no response to this regimen, think about enterococcal and pseudomonas, which again complicates in many times with catheter-associated UTI. Next slide. So, in UTI, antibiotic choice and duration are determined by classification of UTI. So, you need to identify which kind of UTI you are going to deal with. The biggest bugs are usually gram-negative pathogens, although enterococcus and staphylococcus approbiticus are the common gram-positive pathogens. And in young women less than 25 years, it's better to screen for chlamydia because this is many times asymptomatic and the risk of infertility and subsequent pairing is very high. Thank you very much.
How many percent do you think that it's diagnostic for UTI in females? How many percent? Microscopic examination.
That's what I told. Pyuria itself, by itself we cannot diagnose urinary tract infection. It just says that somebody is shedding WBCs. It can be due to many causes. Even drug intake like genocides or many antibiotics, beta-lactam are associated with pyuria. So they are non-specific, whatever amount they are. You should have a clinical picture with fever in presence of that positive urine culture to say somebody dogmatically has urinary tract infection, rather than saying identifying consults and saying somebody has urinary tract infection.
One more question. How about the colony count which is being used? How many colony count is necessary to make a tax?
That's the most controversial area. That's why I have avoided in such a short presentation. It's difficult to finish that. And the most important thing is we have 10 to the power of 5 only in case of asymptomatic individuals. If suppose even you identify a single colony in a suprapubic aspirate, it is significant. In between there are some diagnostic, for example, IDSA says 10 to the power of 4 in women and 10 to the power of 3 in men. In any symptomatic individual is enough. So we have 3 categories. Any positive in suprapubic aspirate, totally asymptomatic individuals it is 10 to the power of 5. In case of men symptomatic it is 10 to the power of 3, whereas in women symptomatic it is 10 to the power of 4. So it keeps changing. So rather than reminding all this, I think just going for the clinical picture may be more than appropriate.
Why you call always in men it's complicated?
That is because many times our prostate is the villain. It actually stores all your bacteria there. And many times this is complicated by reinfections and relapses. That's why all in general we are very, compared to women, we are what shall I say, less likely to develop urinary tract infection. If you develop urinary tract infection in general in men, you need to evaluate your lower urinary tract. Either you have abnormal prostate or a problem with the lower urinary tract with incomplete emptying or a urethral stricture or so. So we need actually, even if somebody has documented urinary tract infection in men, you need to do, after treating UTI, a thorough detailed lower urinary tract evaluation. That's a must.
Time to reduce capsules are being heavily marketed.
Yes, it is available.
Give for 3 months and then after the antibiotics and prevent infection. It's evidence-based.
It is evidence-based to a certain extent, but not level 1 evidence, I would say. We don't have a randomized control trial to conclusively prove that, but we have level 2, 3 studies saying to a certain extent, yes, it reduces urinary infection. Particularly, this is only subject to only E. coli UTI, because they have a substance called proanthocyanidin, which actually blocks this or binds with E. coli receptors. It only actually reduces E. coli UTI, not non-E. coli UTI, as per evidence.
Thank you, Dr. Ramprabhakar, for your elaborate presentation.